Hello, everyone, and welcome to Rehab Podcast Weekly. Today, we're diving into the topics Parkinson's disease, pathogenesis, and diagnosis.
When we talk about Parkinson's disease, that classic tremor often jumps to mind first.
It really does.
But there's so much more to it.
Yeah.
It really affects how people move, their whole well-being.
Yeah.
It's surprisingly complex.
Absolutely.
So today, on the deep dive,
Yeah.
we're going beyond the surface. We've looked at some recent medical literature
Yeah, quite a bit.
to really unpack the core stuff about Parkinson's, like what might cause it, how does it actually show up, the signs and symptoms, how it gets diagnosed, and how doctors track its progression.
Exactly. And just to be super clear up front, we are not getting into treatment options today.
Right, keeping it focused. We want to build that solid foundation first.
That's the plan. Giving you a clear picture moving past just that image of the tremor.
Okay, so let's dive right in. Fundamentally, what is Parkinson's disease?
Okay, so it's what we call a progressive neurodegenerative disorder. Basically, it gets worse over time, and it involves damage to the nervous system. Specifically, damage and loss of certain brain cells, the ones that make dopamine. They're in a part of the brain called the substantia nigra.
Dopamine. That's key for movement, isn't it?
Crucial. And another thing we see microscopically are these things called Lewy bodies. They're basically abnormal clumps of a protein, alpha-synuclein, inside the neurons that are left.
So damaged dopamine cells and these protein clumps.
Yeah.
Got it. How common is this?
It's actually the second most common neurodegenerative disease out there, right after Alzheimer's.
Wow, second most common.
Yeah. And the projections are pretty concerning. They suggest the numbers might actually double in the coming years, mostly because populations are aging globally.
That's significant.
And right now, unfortunately, we don't have a cure or, any guaranteed way to prevent it from starting or slow it down definitively.
That's a tough reality. So what actually starts this whole process? What are the risk factors?
Yeah, that's the million-dollar question, really. We don't have one single cause pinned down, but we know several key factors. Age is the biggest one, by far.
Okay, older age.
And gender seems to play a role, too. Men are diagnosed more often than women. The ratio is about 3 to 2.
Interesting. What about genetics? Does it run in families?
It definitely can. There's a strong genetic component. Researchers have found over 90 genetic spots, or loci, linked to Parkinson's risk.
90. Wow.
Yeah, but it's usually not just one bad gene causing it. It's more often a complex mix of several genes interacting with other factors.
Like environmental things, lifestyle.
Exactly. Things like exposure to certain pesticides, maybe pollutants in water. Those have been linked. And also behaviors.
Such as?
Well, there's research looking into tobacco use, interestingly, sometimes associated with lower risk coffee consumption, how much you exercise, even head trauma history. But it's important to stress the exact way these things might contribute isn't fully understood yet. It's still being investigated.
I remember hearing something about the gut, a gut-brain connection in Parkinson's.
Yes. You're probably thinking of the brake hypothesis. It's a really fascinating area of research right now.
Tell me more.
So the hypothesis suggests that for some people, the disease process might actually start way down in the gut's nervous system, the enteric nervous system.
Starts in the gut, not the brain.
Potentially, yes. And then it might sort of spread upwards towards the brainstem and eventually into the brain itself.
That completely flips the usual thinking.
It really does. The idea involves changes in the gut bacteria, the microbiome, maybe increased inflammation down there, and that alpha-synuclein protein clumping up, but starting in the gut first.
How solid is this idea?
Well, it's still technically a hypothesis, but there's growing evidence supporting it. From animal models and some human studies, it suggests we might need to look way earlier, maybe even at gut symptoms, for the very first signs.
Any other new ideas about what kicks off the brain cell damage?
Yeah, some newer research is also pointing towards another protein called tau. We usually associate tau more with Alzheimer's, but it seems it might also play a role in the early neuronal damage in Parkinson's, alongside alpha-synuclein.
Okay, so multiple proteins might be involved early on. It's clearly complex. Let's shift to how it looks in a person. What are the signs and symptoms?
Right. We usually split them into two main groups: motor symptoms affecting movement and non-motor symptoms. And it's really crucial to know about both.
Why is that?
Because some non-motor symptoms can show up really early, sometimes even years before the movement problems become obvious.
Okay, let's start with the motor ones then. What are those early sort of classic signs?
The main ones, the cardinal features, are bradykinesia, rigidity, resting tremor, and changes in gait or walking.
Bradykinesia. Sounds technical. What is it exactly?
It's basically slowness of movement, but it's more than just being slow. It's also a lack of spontaneous movement and a reduction in the size or speed of movements when you repeat them.
Can you give examples?
Sure, like someone might not swing one arm as much when they walk, or their facial expression might become less animated, kind of mask-like. Handwriting often gets smaller and smaller. That's called micrographia.
Oh.
And if you ask them to tap their fingers quickly and repeatedly, you'll often see the taps get slower and smaller.
Mm-hmm.
Having this bradykinesia in a limb is actually essential for the diagnosis.
Got it. Slowness and movement fading out. What about rigidity?
Rigidity is muscle stiffness. When a doctor passively moves someone's limb, they feel this consistent resistance through the whole range of motion, like bending a lead pipe.
Lead pipe rigidity. Okay.
Yeah. And sometimes, if there's also a tremor, it can feel like a ratchet or a cogwheel turning as you move the limb. We call that cogwheeling.
And the tremor itself, the shaking.
Right, the
Right.
resting tremor. It's common, often one of the first things noticed, usually low frequency, like 4 to 6 shakes per second. It often starts on one side of the body.
Asymmetric, right?
Exactly. Often in the hand, the classic pill rolling motion description comes from that, but it can be in the legs, lips, chin, jaw too.
And it's a resting tremor.
Yes, meaning it's most obvious when the limb is relaxed, supported. It tends to decrease or stop when the person deliberately moves that limb.
Oh, interesting.
But it might come back once they hold the limb still again. But here's a key point. Not everyone with Parkinson's has a tremor. You don't need tremor for the diagnosis.
Okay, that's important. No tremor doesn't rule it out. And the last early motor sign was gait, walking changes.
Yep. Early on, it might be subtle, maybe reduced arm swing on one side, maybe dragging one foot a little, or a slightly stooped posture starting.
Do these motor things change over time, get worse?
They do. As the disease progresses, you can see other motor features develop, and these later ones sometimes don't respond as well to the standard dopamine medications.
Like what kind of features?
More significant posture problems, bending forward quite a bit, maybe leaning sideways, which is called Pisa syndrome,
Yeah.
or a really flexed trunk known as camptocormia. Sometimes the head drops forward. Freezing of gait is a big one, later on suddenly feeling like your feet are glued to the floor. Or the opposite, festination, where steps become uncontrollably fast and short.
That sounds really challenging for getting around.
It is. Balance gets worse too, leading to postural instability and more falls. Speech can become slurred, dysarthria, and swallowing problems, dysphagia, can also occur. It really impacts daily life and independence.
Wow. Okay, let's go back to those non-motor symptoms you mentioned. Could appear early. What are we talking about there?
Yeah, this is really striking. Things like a reduced sense of smell hyposmia that's very common early on.
Loss of smell.
Yes. Also, sleep problems are frequent. REM sleep behavior disorder is a big one where people physically act out vivid dreams.
Oh, wow.
Plus insomnia, restless legs, being very sleepy during the day. Then there are neuropsychiatric issues, apathy, anxiety, often mild depression,
Okay.
and autonomic problems, the body's automatic functions. Constipation is incredibly common, and like I said, can show up years before motor symptoms.
Years just from constipation.
It's a known early sign in many cases. Also, issues like delayed stomach emptying, urinary problems, erectile dysfunction, drops in blood pressure when standing up, causing dizziness, orthostatic hypotension, and trouble regulating body temperature.
That's a huge list, and none of them are about movement.
Exactly, and even mild cognitive changes, maybe trouble with planning or attention, can occur early, plus various types of pain or sensory disturbances.
It really paints a different picture of the disease. Do these non-motor symptoms also worsen later on?
Yes, generally they do. And in later stages, dementia can develop in maybe around 30% or more of patients, often affecting visual spatial skills and memory. The earlier non-motor issues often become more severe too, really impacting quality of life.
Okay, so given this huge range of possible symptoms, motor and non-motor, early and late, how do doctors actually diagnose Parkinson's? Is there a single test?
Unfortunately, no single definitive test yet. The diagnosis is still primarily clinical. It relies heavily on a skilled neurological examination, ideally by a movement disorder specialist.
So the doctor's expertise is key.
Very much so. There are specific criteria used, like the Movement Disorder Society or MDS, clinical diagnostic criteria. They're an update on older ones.
And what do those MDS criteria look for?
The absolute requirement is bradykinesia, that slowness and reduction in movement we talked about.
Right.
Plus, you need at least one other cardinal motor sign, either rigidity or the resting tremor.
Okay, bradykinesia plus one more.
Yes. But it's not just ticking boxes. The criteria also look for support features, things that make Parkinson's more likely. And importantly, they check for the absence of red flag signs that might suggest it's actually a different condition, like atypical Parkinsonism. And they look for exclusionary criteria, too.
So it's a process of weighing evidence.
Exactly. Clinical judgment is crucial. The criteria even have levels of certainty, like clinically established versus clinically probable PD, because it can be harder to be certain early on. Diagnostic accuracy usually improves over time as the picture becomes clearer.
You mentioned red flags for atypical Parkinsonism. Can you give some examples?
Sure. Things like a really poor response to levodopa medication, which is usually helpful in PD, or very early severe autonomic failure that might point towards MSA, multiple system atrophy. Problems with vertical eye movements could suggest PSP, progressive supranuclear palsy. Parkinsonism, staying stuck on one side and not responding to meds, might suggest CBD, corticobasal degeneration. These are clues it might be something else.
What about tests? Do things like smell tests or brain scans help?
They can provide supportive information. That smell test, assessing olfaction. Hyposmia strongly supports PD and helps distinguish it from some other conditions.
Okay.
Analyzing the tremor itself, maybe with EMG, can help differentiate it from, say, essential tremor.
What about imaging, MRI, DIAT scans?
A standard brain MRI is often done mainly to rule out other things, like strokes or tumors. More advanced MRI looking specifically at the substantia nigra is mostly research for now.
And DAT scans?
Dopamine transporter scans, DDAT scans. They look at dopamine nerve terminal function. They can be helpful sometimes. If someone has symptoms that look like Parkinson's, but the scan is normal, it makes PD very unlikely. That situation is sometimes called sweetie scans without evidence of dopaminergic deficit.
So a normal scan is useful for ruling out PD?
Yes. But, and this is critical, an abnormal BAT scan doesn't distinguish PD from atypical Parkinsonism because both involve loss of these dopamine terminals.
Ah, I see.
So it's not a routine diagnostic test for everyone, but may be helpful if the diagnosis is uncertain or for confirming dopamine deficiency in research trials.
Any other tests on the horizon? Biomarkers?
Yes, research is very active here. Testing cerebrospinal fluid, the fluid around the brain and spinal cord, is promising. There's a technique called RTQIC that detects abnormal alpha-synuclein seeding activity.
The protein clumps again.
Exactly. It shows really high accuracy for diagnosing Parkinson's in research settings. And genetic testing is also becoming more common in the clinic to identify specific subtypes.
Okay, so once the diagnosis is made, how do you track progression? How do you stage the disease?
Staging helps gauge where someone is in the disease course. The most commonly used scale, mainly because it's simple, is the Hone and Yar scale, or H&Y.
Hone and Yar. How does it work?
It has 5 main stages based mostly on motor symptoms and balance.
Can you run through them quickly?
Sure. Stage 1 is symptoms on just one side of the body. Stage 1.5 adds some trunk involvement. Stage 2 means symptoms on both sides, but balance is still normal.
Okay.
Stage 2.5 is mild bilateral disease, but they recover on a balance test called the PUL test. Stage 3 involves mild to moderate bilateral symptoms. Some balance problems start, but the person is still physically independent.
Getting more involved now.
Right. Stage 4 means severe disability, but they can still walk or stand without help. And Stage 5 is the most advanced, typically wheelchair-bound or bedridden unless they have assistance.
That gives a clear progression based on motor function. But you said it's mostly motor.
Yeah, and that's its main limitation. The H&Y scale doesn't really factor in the impact of all those non-motor symptoms we discussed, which can hugely affect someone's quality of life.
So is there a more comprehensive tool?
Yes, definitely. The MDS-UPDRS, that's the Movement Disorder Society's revised Unified Parkinson's Disease Rating Scale, is much more detailed.
MDS-UPDRS, what does that cover?
It has 4 parts. Part 1 looks at non-motor experiences in daily life. Part 2 is about motor experiences in daily life, how symptoms affect activities. Part 3 is the actual motor examination by the clinician. And Part 4 assesses motor complications like dyskinesia or wearing off of medication effects.
So Part 3 is where the clinician scores the motor signs directly.
Exactly. It involves assessing many things: speech, facial expression, tremor at rest and with action, rigidity in the neck and limbs, getting out of a chair, walking, checking for freezing, testing postural stability with the PUL test, observing posture, and overall spontaneity of movement. It's a very thorough motor assessment.
Like watching how someone turns in bed or how steady they are when walking and turning?
Precisely. It looks at tremor severity, how rigid the limbs are, their balance reactions, posture when standing. It gives a much richer picture than just the H and Y stage.
It sounds like the MDS-UPDRS provides a much more holistic view of how Parkinson's is affecting the person.
It really does. While H and Y gives a quick snapshot stage, the MDS-UPDRS captures motor, non-motor, and functional aspects in much more detail.
Well, this has been incredibly informative, a real deep dive. Parkinson's is clearly so much more complex than just a tremor. The range of symptoms, the potential causes still being explored.
Absolutely. And getting that diagnosis right, even though it can be challenging, is so important. Understanding the progression using tools like H and Y, or even better, the MDS-UPDRS, helps track things over time, even if we didn't touch on the management side today.
Right, and like we said up front, treatment was intentionally off the table for this discussion. That's probably a whole other deep dive in itself.
Oh, definitely. There's a lot we could cover there.
So as we wrap this up, I'm just struck by the sheer breadth of this condition. Thinking about everything from losing your sense of smell years before a tremor starts, to the gut connection, to the balance and movement issues later on. What's the one thing about Parkinson's from our chat today that surprises you the most? Or maybe raises new questions for you about how our nervous system works, or about neurodegeneration in general?
That's a great question to ponder.
Definitely something for you, our listeners, to think about too. Until our next deep dive.
Edited by Min.Rehab. Thank you all for listening, and see you in the next podcast.